So I have no financial interests. And special thanks to resident Chris Desome, who is a second-year resident who helped put this together. So some of our objectives. We'll talk about what is a cataract, what causes it, what are the types of cataract, what are some of the symptoms you can expect to experience with a cataract, and how do we treat cataracts? So a cataract can be associated with aging and also with systemic diseases. It can affect your quality of life. And the way we treat it is with cataract surgery. And this is the eye here. And you can see this is a clear lens. When it becomes cloudier over here and opaque, it'll affect your vision. A cataract is a term used to describe the clouding of the crystalline lens in a human eye. And primary care providers, that means your family doctors and nurse practitioners, play a key role in diagnosing this because these are the professionals that will refer you to an ophthalmologist for cataract surgery. There is no medical treatment for cataract. Sure. There is no medical treatment for cataracts. Minimizing exposure to risk factors can slow the progression of a cataract. And glasses can help with some of the symptoms for a brief period of time, but glasses don't help with cataracts for long term. And the treatment for cataracts is cataract surgery in order to improve a patient's quality of life. Cataract surgery today is done through phaco emulsification. That means an ultrasound breaks apart the cataract into small parts and then sucked out of the eye. So this is a cartoon of the eye sliced in half. And this is where the cataract is here. And when light comes in the eye, it can cause a lot of glare, and therefore the image is not focused on the back of the eye, called the retina. And then this image goes to your brain, from the eye to the brain. If you see a cloudy image, your brain is not going to register a crisp image. So the lens is behind the iris, which is the color part of your eye, and it's usually clear, and it focuses light, and allows you to focus on near and distance. Cataract becomes cloudy with time, and with normal aging, there are a lot of insults that lead to proteins collecting in the lens, and there are different types of cataracts. And the removal of this cataract and a placement of a new lens made out of acrylic, which is a kind of plastic, is known as an intraocular lens, and that helps improve your vision. And so this is probably the most common cataract that we see in people over the age of 75, and it's very white. And 90% of blindness in developed countries like Canada, the United States, and Israel is attributed to cataracts, and it can vary by age, sex, and race. And in the US, the nursing home population of cataracts is a leading cause of low vision. And there are different types of cataracts. I won't go over all of them. I would say that it's safe to say that most of you in this room probably have it due to maturing. Here are the different types of cataracts. As you notice, I don't like to use the word age, but there are different kinds of cataracts here. This is due to maturity. This is due to trauma. This cataract here is due to trauma. And so there are different types of surgeries to take care of that. Most of you have this kind of cataract here. And then you can have different types of cataract that happen with maturity that change over a different population. And it's a normal yellowing and sclerosis of the lens. And we see this more in Caucasians, but we also see it in African Americans and Asians. This is what it looks like. And then you can have cortical cataracts, which really cause a lot of glare and halos. And it looks like that, okay? And then there's plaque-like cataracts that can happen really, really quickly. Some of you in this room may have noticed maybe over months, your vision's going down quickly. This is a kind of cataract called a posterior subcapsular cataract. And that's what it looks like. And that can affect the vision severely. Now, other things can affect cataracts. If you have diabetes, it makes it go faster. And if you have other types of diseases, it can make the cataracts progress much faster. And these are just different types of cataracts here. I don't think it's advancing. Oh, is it? Okay. And that's a traumatic cataract. So usually over time, people say, you know, doc, my vision's kind of blurry, but sometimes this progression happens over time and your optometrist gives you a pair of glasses. And then you come to a point where like, hey, I can't see well. I'm 20/50. I can't drive at night anymore. And patients are often unaware when this happens until they get a pair of glasses. It doesn't help them anymore. And when patients are asked about symptoms, most people say it's glare at night and halos, or doc, my glasses are just not working. But sometimes people have a hard time explaining what they're not seeing. But these are what some of the symptoms look like: glare, blurred vision in a bright light, reading difficulties, and a myopic shift. Myopic shift simply means I can't see very well at distance like I used to. And so when light goes in the eye, it creates glare. And this is what it looks like. With somebody who has a clear lens, they see a sharp image. When they have glare, all this light gets dispersed and it's blurry. So, sure, I'm sorry. So when asking patients about vision, it's important to ask specific questions. Questions related to what you do in your life. Can you read? Can you watch TV without difficulty? Can you see your grandchildren? Can you read the Siddur? Things like that. Do you see well enough at night to drive? This is the #1 problem that my veterans have when they come to see me. Are you able to read print on your medication bottles? Can you read well without difficulty when you watch TV? And up through the 1960s, surgery was just removal of the cataract and nothing else. And then we would give patients glasses. But through the 80s and 90s and in the 2000s, things changed very quickly. And this had a lot to do with an accident that happened with one of the pilots in England. He crashed and he got glass in the eye and he was actually able to see better. And that showed many doctors that glass can be tolerated in the eye. And that was the beginning of our understanding of placement of lenses in the eye. And this gave way to the evolution of intraocular lenses. So the intraocular lenses are placed in the eye after cataracts are removed, and they're made out of acrylic. And they look something like this, okay? And there are different types of lenses. There are lenses for distance vision, intermediate vision, near vision, and all types of vision in between. If you have Medicare, Medicare will only pay for one kind of lens, and you can choose either distance or near. If you have private insurance, some will pay for specialty lenses, which are multifocal, but not all of them. The multifocal lenses that give you near, intermediate, and distance, sometimes you have to pay out of pocket for that. And this is what happens. When the lens is removed from the eye, the doctor inserts an artificial lens in the eye through a small opening, and it rests in your eye. And it creates a clear opportunity for light to come in the eye and focus a clear image on the back of your eye. And most lenses today are either made out of acrylic or silicone. And we can also correct near vision, which is known as hyperopia or myopia, distance vision. We can correct astigmatism. And today, cataract surgery has gotten so much better that in many patients, we can safely say that this is going to be successful and improve your quality of life. And in many cases, you may not need glasses either for distance or near. And this is the size of a lens that'll go in your eye. It's one of the smallest implants in the human body. In the past, cataract surgery was very barbaric. We used to make large wounds in the eye, but today, the smallest wounds that we make in the eye for cataract surgery are between 1.5 and 2.4 millimeters. That's quite small. That's under an inch, under half an inch, in fact. And so in the past, we used to remove the whole cataract as one big disc, and that was a very barbaric surgery. And we used a lot of stitches, but today we don't use stitches for that surgery. This is what the old surgery used to look like. And in this old surgery is now done in the third world in places like Africa, but in the United States, we don't do this old surgery called extracapsular cataract surgery. We do phacoemulsification. So in modern cataract surgery, we emulsify and suck out the lens through an ultrasound or laser. Here it says small incision 3 to 3.5. Today it's even much less than that. I perform a surgery of 2.4 millimeters and the lens is folded. And this is what the beginning of the surgery looks like. And the advantages here are minimal astigmatism, and you heal really quickly from this, and there isn't much trauma to the eye, and most people are awake for this surgery. You only need a topical anesthetic or a little bit of Versed like Valium, or a little bit of local anesthetics. Most people don't need to be put under general anesthesia for this. And this is what the eye usually looks like on one day after surgery. So some of the disadvantages, sometimes the energy can be too much, but that's rare. And that's what it can look like. But this is extremely rare. Let me say that 99% of these surgeries are very successful. This is just another risk where the cataract could fall back in the eye or an infection, but this is to show you that it's very rare, 1 out of 1,000. Loss of jelly, extremely rare. And if a part of the cataract falls back, we have the way to get it back, and still people see very well after surgery. These are some of the complications. I'll avoid those for now, but they're very rare. This is infection in the eye, pain, which is rare, vision loss, extremely rare, and an inflamed eye, and infection. And sometimes after cataract surgery, you can get a secondary cataract. And what that is it's a little cloudiness of the lens because small cells remain in the eye after surgery. The doctor can't take out all the cells. So they cause like an opacity on the back of the lens. And sometimes to improve somebody's vision when it's cloudy, we do a laser. That's quite common. And that laser takes 5 minutes and it's in the clinic. So this is before, and that's after the laser. And I do these lasers probably about 10 a week. So what's the future of cataract surgery? Multifocal intraocular lenses. Those exist today. They're not perfect, but in many patients, they work well. And they help patients see at near, intermediate, and distance vision, and it allows many patients to see well without glasses. But it's not for everybody, especially if you have a disease like macular degeneration, glaucoma, or you've had a stroke in the eye. This kind of lens is probably not for you because this lens can reduce your contrast in your eye. Flexible IOL. This lens allows the lens to move forward and backward to give you vision at different distances. That's a new lens, and that tends to work very well. And our surgeries are getting better. We are performing surgeries with much smaller incisions. And we have safer surgeries. Today, there are laser cataract surgery where part of the surgery is done with a laser before we enter the eye, making the surgery that much safer. So in summary, a cataract is a result of the cloudiness of the lens that you're born with in your eye. And it can cause visual disability. It can make your vision blurry. It can affect your quality of life. But today we can successfully treat it with cataract surgery, which is known as phacoemulsification. And just so you know, you shouldn't feel bad if you have a cataract, because guess what? If we all live long enough, we're all going to get a cataract, including me. Your primary care doctor, your nurse practitioner, or your physician assistant has an important role in screening you for cataracts, and so does your optometrist. And either one of those people will refer you to an ophthalmologist to be evaluated and treated for a cataract. And that's it about cataracts. Any questions? Sure.
Let's just start on this side because I'm choosing one side or the other.
I have a question. What if you're allergic to acrylic and you're not sure if you're allergic to the silicone? Can they do it with glass or they not?
So there are other types of lenses made out of different material. We don't insert glass anymore, but that's a discussion that you should have with your doctor. One thing you can do is an allergy test before, but typically these lenses that we insert in the eye, a patient doesn't have an allergic reaction to. There's no immunologic reaction, but if you do have an allergy to something like that, that's something you should bring up with your doctor, because there's a wide variety of choices of lenses. There are some that are more rigid that are not made out of those materials, but that's a good question.
What causes color blindness?
So that's a very good question. Color blindness is inherited, and it's typically inherited among males, and it's a genetic condition. And sometimes color blindness can be very mild, and sometimes it can be severe, and it affects the cones, which are the color receptors in your retina, which is the back of the eye. If you can imagine an old-fashioned camera with film, that's what our eye is. The retina is like a film of a camera, and the lens is like our cataract lens. So our film, if you have color blindness, is missing some of the cones of certain colors. So people are born that way, and it's typically men.
Slide said something about risk factors, and I was wondering if those are something that's controllable to slow down, what's happening and like what you do.
Sure. I sort of glossed over it, but here are some of the things that you can do. If you're a diabetic, for example, try to control your diabetes as best as you can, and that'll slow down the progression. Wearing sunglasses, especially in the desert, to protect your eyes from UV light. Also, if you have high blood pressure, controlling that as well. Those are the main conditions that you can try to control that's within your control. Some things that are not in your control, for example, if you have high cholesterol or you have other diseases, there are medications that we all take. Some of those medications may allow for the progression of the cataract much faster, but we need to take them in order to survive. So I would say wearing sunglasses, also taking vitamins, multivitamins as well, avoid sun gazing, and if you're a diabetic or you have high blood pressure, controlling that as best as you can. Sometimes it's not always possible, but those are the main things I would say. And leading a healthy lifestyle and diet. And not smoking.
Why does removing floaters cause cataracts?
So that's a very good question. Anytime you operate on the eye, it's not a natural situation. And that itself can cause the progression of a cataract very quickly. Any energy you deliver to the eye and so forth. So if you remove floaters, you're actually going in and removing part of the jelly part of the eye, and any eye surgery can promote the development of a cataract. Trauma to the eye, getting punched in the eye, playing pickleball, getting the pickleball in the eye can cause a cataract. So I want to tell all of you, if you play tennis, if you play pickleball, wear safety goggles.
And a lens be replaced.
Yes, it can. So sometimes patients are not happy with the lens that's placed in their eye. Sometimes it's the wrong lens. The doctor does a calculation and it doesn't come out right. The other surgery is to remove that lens and put a new lens in the eye. It's not an easy surgery, but it can be done, and I've done those.
Okay, I'm gonna come.
Sure.
If you get the, if you get the, if you get the lenses from Medicare, but then can you wear glasses afterward or not?
So yes and no. If you get them from Medicare, Medicare will only pay for a standard lens, either for distance or near. But
Choice?
you have a choice, and you can choose that with your doctor. You can say, "Hey, doc, I like to read the stocks on my computer. This is what I do all day." He or she will put in lenses for near, but you need to tell them that. Or if you like to shoot and drive, you can say, "I want a distance lens." But the Medicare won't pay for both. If you want a specialty lens like multifocal or an accommodating lens, you will have to pay out of pocket. Or if you have a really great insurance.
So the bottom line is, if you get the, will have glasses one way or the other.
That's right. But then you can set up one eye for near and one eye for distance. That's a monovision. And some people do very well with that without glasses.
Great.
Yeah, that's true. Adjustable brain.
Hi, doctor. Two questions. Dry eye syndrome, or this is a contributor, this is in making on quicker than cataracts. And two, you have both of them in the same time.
What was the second question?
Can you have both eyes done at the same time?
Okay, so the first question is, let me see if I understand it. Can dry eyes bring on cataracts? Can they exacerbate it? They can exacerbate the symptoms of cataracts because cataracts causes cloudy vision. So does dry eyes. Dry eye, so if your eye is very dry, the front of your eye can become scratchy, and then the image that you see is cloudy due to the dry eye and the cataract. But the dry eye itself doesn't cause the cataract to accelerate, okay? So for the dry eye, especially in the desert, we need to stay ahead of the game. Like we hydrate our bodies and not wait till we're dehydrated. We need to lubricate our eyes constantly. But cataract surgery won't improve dry eyes. That'll stay for a long time. And the second question,
Having both eyes done at the same time.
in some centers in the United States, in private practice, typically it's not done because Medicare doesn't pay better for two eyes done at once. But in the VA system, in some centers, we do it to help out our veterans who can't go through one surgery at a time. They need to be under general anesthesia. So we'll do two at one, but it's not common. It's done more in Europe.
Hi, thank you for your presentation. It was excellent.
Thank you.
And I had cataract surgery in Europe. I think he did one for far and one for close, and I didn't have to pay anything, so maybe I put insurance.
I think.
And my next question is, so I do need glasses to read. So what is is number 3 better if I don't see as well, or number 2? I'm very confused with that.
So I'll give you a quick way to guide yourself. So first of all, what you're talking about is monovision, what the gentleman, I talked to the gentleman here about. Medicare will pay for that, to set one eye for distance and one eye for near. But you have to tolerate that. And usually the people that tolerate that well have had contact lenses like that, okay? And if you did it and you're tolerating it well, great. The second question is about what glasses should you use, +3, +2, +1. That depends what you're reading. So let's say you take a magazine. I would recommend go to the dollar store, hold the magazine up like this, put on a +1, +2, or +3, and see which one is the sharpest with the least amount of power at this distance. But let's say you're working at a computer and it's about 3 feet away. So you know what you do? Buy some cheap pair of over-the-counter glasses at +1, at +2, bring them home and try it with a computer at a different distance. And what works well for you at the lowest power, that's what you should choose. Does that make sense?
Oh, yeah, I've done that. But-
Okay.
But it doesn't, so there's no standard like.
No, it's what the patient can tolerate at the lowest number. That's what I would recommend.
I actually ordered from Amazon.
Okay,
I had cataract surgery. Can I replace my implants once they put them in?
you can, but it would depend on the reason why you want to do that. Why would you want to do that?
Because they're getting worse.
So if they're getting worse, what I would recommend that you do is go back to your ophthalmologist, have your ophthalmologist examine your eye and tell you why it's getting worse, because it may not be the lens. It could be, and you could have a secondary cataract, which is an opacity for which you may need a laser, or you could have something else going on. And you really want a physician to tell you, well, Mr. Schwartz, this is why your vision has gotten worse, because either you have dry eye or maybe you have macular degeneration, not you, but there could be other reasons. So if that ever happens and you have doubt, speak to your ophthalmologist, have an exam and ask the doctor, why am I not seeing well? Does that make sense?
Yeah.
Good.
Any other questions?
My daughter has had implanted lens for vision for many years. If she starts to get cataracts, what kind of surgery would she be facing?
I'm not sure exactly what surgery your daughter had, but there are some surgeries where people get lenses in the eye, intraocular lenses, and their cataracts or their native lenses aren't removed. If that's what you're telling me, and she needs surgery in the future because she developed a cataract, she could either get another lens placed in the eye, that would be called a piggyback lens, or the doctor may take out that lens and take out the cataract and put in a new lens. But it's purely hypothetical. I need to know more about what your daughter had exactly implanted in her eye.
Thank you.
You're welcome.
Color blindness.
What about it?
Double vision.
What about double vision? Okay, so there are many different causes of double vision. Sometimes double vision can be caused by dry eye. So if you cover one eye and you see two, and then you cover the other eye, and you see two, chances are it's either a dry eye or a problem with your retina. If you have double vision, side to side or up and down, and you cover one eye and it goes away, it's the way your brain controls your eye movement. And that's either due to a brain problem or an eye muscle problem. In both cases, you need to see an ophthalmologist, okay?